This module is going to focus on the basics of reimbursement in the United States healthcare system. We're just going to be skimming the surface here in regards to the different intricacies of reimbursement. If you are looking for more information or do see yourself in a career where you're going to be dealing a lot with reimbursement, I would highly suggest that you take a budgeting and finance class to get a little bit more in-depth information in terms of reimbursement, because as I said, we're just going to be skimming the surface here in regards to reimbursement. So we can see here this chart goes over the cost of services in the United States healthcare system starting about 1960, and we have it projected all the way up through 2020, which in 1960 we can see it was fairly stagnant. I'm sure if we back that timeline up a little bit, it would be more of a straight line up through 1960. And we get to 1965, we have the creation of Medicare, Medicaid services, and we start to see healthcare kind of propel up this chart, and we see healthcare spending drastically increase, with hospitals, physicians, and clinic offices making up the majority of that care, which we're going to talk about later throughout the module. So I want to make sure to note here, previously and historically, the attempts to really curb the cost of healthcare have more often than not resulted in an increase in the administrative costs, which unfortunately that doesn't really do much, because providers, hospitals, clinics, they're going to find a way to get around and to decrease those costs, and unfortunately that often comes in the form of an RIF, a reduction in forces, or cutting jobs, things like that. So what we're looking here on this chart, this is called your payer mix, and these are all the primary payers for healthcare services in the United States. So we have Medicare, Medicaid, VA insurance, private insurance, out-of-pocket, and then other types of means for paying for healthcare services. And again, like I said, this is called your payer mix, so it's what percent of your patients use HMOs, what percent use Medicare, Medicaid, private insurance, VA. What does your breakdown look like across your patient population? And it's important for you to understand this as a manager and as a supervisor, because you want to see where that money's coming in from, and you want to have a healthy payer mix. So, for example, our lowest reimbursement on this chart probably would come from Medicaid. They are notoriously low reimbursers. So we want to make sure that we have a healthy enough payer mix with Medicare, private insurance, out-of-pocket to kind of compensate for the lower reimbursement that we're going to receive from Medicaid. And when we move on over and kind of take a look at public versus private insurance, public is going to be things like your Medicare, Medicaid, going to be things like your TRICARE, and private is going to be more like your Blue Cross Blue Shield, Aetna, Humana, things like that. But what I want you to pick up on this slide and really start to notice is what does the mix look like as we move from 1960 up through 2018? We start to see a change where public insurance funding is increasing, and private insurance funding is decreasing. So we're starting to rely more on public insurance for methods of payment than for private insurance. So with the RBRVS, or the Resource-Based Relative Value Scale, Medicare here is really going to set the pace on what providers are going to be reimbursed. And your HMOs, your PPOs, those different types of plans are really going to follow suit on what Medicare does. And the last one we'll talk about are your RUGs. Your RUGs are similar to your DRGs that you see in the hospital, but these are used for skilled nursing facilities. So you're being reimbursed based on the intensity of services, your patient diagnosis, your ADLs, activities of daily living, your number of minutes, your therapy, things like that. You're going to be reimbursed on a RUG rate or a resource utilization group rate. Now this was a fairly short one. We're going to end here. There's one more slide that I'll go through, but if you have any questions, please feel free to let me know.